Mark Larson is the former Medicaid director for the state of Vermont. He's now vice president of policy at the Center for Healthcare Strategies and provides leadership training for Medicaid directors across the country.
Thank you. It's a pleasure to be here. It's wonderful. I was commenting about how nice you've made Delaware weather here in November. It's lovely, warmer than Vermont. Again, my name is Mark Larson. I currently work for the Center for Healthcare Strategies, but that actually isn't as directly related. My personal history with this topic, I was chair of the Health Care Committee in the Vermont Legislature and the House of Representatives during the time that Vermont passed Act 48, which was our creation of our health benefit exchange, the Green Mountain Care Board, and our attempt at universal coverage called Green Mountain Care. And most relevant for today's discussion is our work around the Green Mountain Care Board. I also then became commissioner of the Department of Vermont Health Access, which is our Medicaid agency in Vermont, and now serve in the role that I am. My hope today, in the time that we have, is to talk a little bit about the background for the creation of the Green Mountain Care Board, and hopefully draw some parallels to the work that you're doing in looking at governance structures here, then talk a little bit about the role of the Green Mountain Care Board. I'm aware that Robin Lunge has been here, and Dr. Craig Jones to talk some about Vermont's efforts, so I will present this primarily in the context of an update and reminder, and then talk about some of the key considerations that we had when we were creating the board through legislation, and then share a couple of thoughts about some lessons learned in that process. Having read some of the documents related to your efforts around the benchmark, they're not dissimilar to the conversations we were having in Vermont during the creation of the Green Mountain Care Board. And I'll say that at that time, a lot of the focus was around our efforts related to single payer, but really that was a consideration, but in all circumstances, much of the dialogue about why we were interested in making change was consistent. I went back and looked at some of our spreadsheets and diagrams and charts and graphs at the time, and we were in a period where over the course of 6 years, our total healthcare expenditures in Vermont had grown by 50%. And when we look at that projection moving forward, we face the reality that healthcare expenditures were easily exceeding any cost index that you could come up with. They were easily viewed as one of the biggest pressures within our state budget, and town budgets, and family budgets, and business spreadsheets across the board. And that we weren't going to be able to sustain that growth rate going forward, and at some point we needed to come up with some strategy for trying to govern that health expenditure at the state level. And by that I don't mean that by state government, but we are a small state. We have a fairly non-competitive healthcare delivery system. Vermonters access basically one system of care, and we needed some way to figure out how do we get the most from that at a cost that we could afford. Despite some of our national attention for good health outcomes, we knew that we needed to do better, and particularly for certain populations. We had parts of the state that certainly didn't see the same outcomes as other parts of the state, and we had populations that didn't see the quality and outcomes that we would want to see for them. And so it wasn't simply about cost, it was also connected to quality, although very honestly, cost was a big driving concern. And then we had a lot of things going on. Folks may know about the Blueprint for Health. I think you've heard from Dr. Jones about the Blueprint. Really good, wonderful things. But at some point we were concerned about, is there alignment with all these efforts? And where does that alignment come from? All of those three factors were really drivers for our consideration of a governance system that gave us an opportunity to do better than we thought we were currently doing. This comes straight out of Act 48 that created the Green Mountain Care Board. It talks about the intent in terms of improving health of the population, reducing per capita rate of growth and expenditures, enhancing patient and healthcare professional experience, which for us in writing it was an important statement that we really did want both. And as much as there was concern on the context of providers about, what is this going to mean, we really did want to improve the experience of providers as well as consumers. We wanted to make sure that we could retain and recruit a workforce that wanted to be in Vermont and wanted to serve Vermonters. And then we wanted things to be simpler in the long run. I took this from a presentation that some of you may have participated in before. You can break some of the responsibilities and duties of the Green Mountain Care Board into 3 areas: regulation, innovation, and evaluation. And this includes in the regulatory arena looking at health insurer rates and rules, hospital budgets, our CON process, our overall health expenditure analysis, implementation of alternative payment models and payment reforms, and oversight now of our ACO models. On the innovation side, they are responsible for overseeing our payment reform efforts and delivery system reform efforts, at building a data infrastructure and helping us develop information that guides our decisions moving forward, payer policy and ACO agreements. And then the evaluation piece. And it may be helpful to see that in many cases, we had somebody doing many of these functions before the Green Mountain Care Board. And in particular, I'll point out that we had a division of state government called the Division of Banking, Insurance, Securities, and Healthcare Administration, which we refer to as BISHCA. And BISHCA, in all of those duties, had responsibility for insurance rate review, had responsibility for overseeing hospital budgets, had the statewide expenditure analysis and the CON process, and oversaw our all-payer claims database. So it was doing a fair amount. And you can see that some of those functions then flowed through or over to the Green Mountain Care Board when we created it. And some of them came as a whole, and some of them came with modification. So for example, I'll point out our rate review process. The Green Mountain Care Board still receives a recommendation from what was BISHCA. It's now called our Department of Financial Regulations, DFR. They still do the solvency consideration in rate review. The Green Mountain Care Board then takes that recommendation, reviews it, but with a new lens around affordability and public good. And so they add a layer to that pre-existing rate review process that is accomplished with the parameters of the Green Mountain Care Board, and then they make final approval of rates. Similar with hospital budgets, the process now flows through the Green Mountain Care Board, somewhat consistent with what was happening before, but now with a greater systemic lens for what does that budget mean in the context of serving Vermonters and the context of affordability. And then CON, all-payer claims database, those things just came down as they were. So I realized that there are differences. We don't have an elected insurance commissioner in Vermont. That was all within state government as part of the executive branch appointed by the governor. So there appreciate differences. But what we did is we tried to look at what were the existing functions, which were the ones that made sense to pull into the Green Mountain Care Board, and were there changes when we pulled them in. I'll highlight this later, but part of what we were considering in terms of which roles to keep and which roles to leave was this notion of how do you align the policy development and the regulatory responsibility. We had a model in Vermont of our public service board which oversees utilities, where we have a public service department and we have a public service board. The department is really the policy place where policy is developed, and the board is really where the regulatory decisions are made. And we thought a lot about at what points does the policy want to be separate from the regulator, and at what point do you want them to be together? We had a state innovation model that came right on the kind of concurrent to the creation of the Green Mountain Care Board, and I'll just highlight some of the function that the SIM grant played for us. It really pushed us in this realm of looking at alignment across payment and delivery system reform efforts. It supported investments around our infrastructure, like our HIT systems. It created a vehicle for the public-private partnership that was so important to our efforts in moving forward in reform, and created a place for public engagement. Many of the things that our ISHCA had done before felt for many people like they went into a dark hole, and then at some other point they came out. And people didn't understand them, they didn't know where they could engage in them, and both our SIM grant and the creation of the Green Mountain Care Board really intended to create an environment where people not only knew where things were happening, but they knew how they could participate in them. And in that context, it created a forum for ideally building consensus, or maybe at other times, simply resolving conflict. And I don't mention it here, but I probably should, that one of the things that it forced us to do is also deal with conflicts of interest. When making decisions, how do you bring out into the open when participants actually may have some sort of a conflict in that decision? So at the time that I was in the legislature and we were dealing with our reform bill, these are a couple of questions that we really struggled with that I hope may be helpful in your considerations. Again, I'll go back to that notion of the relationship between the policy development and the regulation. There's the who sets the policy and then who evaluates decisions based on those policies. We spent a lot of time looking specifically at this notion of the difference between an independent body versus a representative body. As we talked more about this, there was a really strong push in writing the legislation, and proposals would come in on a regular basis about, isn't it important that so-and-so is at the table and is a member of that board? And we really pushed back because the notion was that the board was going to be the place that we had coherent oversight over the entire system that served Vermonters. And we had some prior history where representative boards got bogged down to a point of inefficiency. And we really wanted to maintain an independent board that could make decisions that were in the best interest of the state and the system and Vermonters, and where folks were responsible not for representing some entity, but were really responsible for looking at the whole. And so that was a really key decision. We drew example from the Maryland Hospital Board, as well as our Vermont Public Service Board, in the push for why independence was so important. And that theme then bled through to a number of other factors or considerations. How big should it be? And we had lengthy conversations about 3, 5, 7. It's got to be odd. It can't be even. Bigger is good because it's more trustworthy that there's more people to be accountable. But big is hard and cumbersome and can get bogged down. And frankly, big costs more than small. And we went around and around and around, actually never changing 5. As much as people argued about it, 5 became our number because it was not so small and it was not so big, and it was odd. And then we went around and around on, well, should there be specific criteria or conditions about the makeup? Should it have to include a practicing provider? Should it have to include a certain set of skills? Should it have, and we really eventually said, no, it shouldn't. It is 5, and we want it to be representative on some level, but we're not going to put that into regulation. What we did do is a couple of things that are the next bullets. First, we struggled with, well, how long do you want them to serve? It became a key consideration in terms of how do you maintain independence. We wanted people to be appointed to serve and then have a long enough period of a term that they could actually think without worrying about reappointment or the next step, that they could actually do something. We also recognize that getting things done in this arena takes time, and if you were constantly turning members, that they wouldn't have the time period to actually play out the kind of work that they wanted to see, and that some of this stuff is really technical, and that it's going to take them some time to develop the expertise to do it. And if you were then off by the time you had just learned that, we wasted that investment. So we eventually came down with 7 years, because it was long, but not too long. I mean, the same kind of conversation. For those of you who have been around legislatures, you know the science to this process, right? And somebody said 7, somebody said, well, no, 4, and then somebody says, oh, you know, we stuck with 7. Also, important to that, we determined that the board members would only be removed for cause. Again, that notion of creating their ability to think for the system without worrying about political ramification. There's always politics to these conversations, but we wanted them to be somewhat insulated from that. And so certainly we wanted to be able to remove people if there was a reason, but we didn't want them to have in their back of their minds concern for other reasons that somebody might come after them trying to get them off. And then in terms of getting public support for a board that seemed well qualified, we modeled off our judicial nominating system, where there's a process where people are not, they apply, they go through a screening with a nominating committee. The nominating committee's job is basically to determine that these folks are qualified. They could do the job. Those names are then passed on to the governor makes an appointment, the appointment is confirmed by our Senate. For us, that was in Vermont a trusted process that had stood the test of time, that we felt like if we could draw from that, it again added to the independence, it added to the ability of the board members to be able to perform their governing role in a way that they felt like they had some security once they got through that process. And then funding and staffing remained an ongoing question. We took a lot of staff from Bishka, moved them to the board. We took a lot of money for that staffing and moved it to the board. And this has been one of the areas that has played itself out most over the course of time. What are the right resources that they needed to be able to do the job well? And what's the right staffing level? We all know that in state governments, how many positions becomes one of the central discussions about budgets and funding, but we worked it out. So a couple lessons learned. One, while it may feel daunting, it actually is possible. We actually did it, and it is now working, and you can look back in Vermont over the past couple of years and see where the board's role has made a difference in our state. And so it really is possible. The independence really mattered. There are numerous examples of where the board has made decisions that probably wouldn't have been made otherwise if they didn't have that ability to be an independent body like we've set it up to be. It's really important that we set them up to be folks who look at the system and can see across the silos, that they're not stuck in the individual levels. I think what is happening now at the board is how do you also get that not just from the board members, but from staff. because many staff have come up in looking at their swim lane in terms of I do CON process, I do rate review, and getting them to see it from a systemic point of view like the board is supposed to, also important. Everything is a work in process, right? Everything changes over the time, but it's important to start from the strongest position possible. Giving them the biggest opportunity to start from a good place seems really important. And then openness is really an essential asset of our board, and it's really hard. Making things open to the public, being able to have a place that can be that place where these decisions get hashed out for the state takes time. You have to build it into timelines. You have to build it into your resource plan. I believe my time is up, so I'll stop there.
Stay. You timed that perfectly. We do have some time for Q&A for a couple of questions. We'll keep it short. Is there anybody that has something right out of the gates? Wow, so why don't we, and it's on the left side of the room too. You guys need to wake up. Why don't we start over here? But let's try to keep it brief though, so we can get as many.
Question with the application process. Did individuals during the application process have to say what party they were affiliated with and when they voted?
No. Folks who apply do not have to do any statement about party affiliation.
I have two. What is the mix of for-profit versus non-profit hospitals in Vermont? And then secondly, has there been any cases since the board came into being where their decision has been overruled by either the legislature or the governor's apparatus?
So we have no mix. We have no for-profit hospitals in Vermont. And I believe that the board's track record is quite good at not having its decisions overturned by either a judicial or political process. I think they've been very mindful of that. And they, while their responsibilities have remained consistent for the most part, the ACO piece is maybe the newest piece that's been added in. I think they've been careful at making decisions that grew with their awareness and strengths so that they could maintain that good track record of not losing cases.
Yeah, hi, Wayne Smith. I'm the hospital guy in the state. Thanks for your presentation. This has been in effect two years, is it, or going on 2 years?
So the Green Mountain Care Board was created in 2013.
2013, okay.
And so a little bit longer than that.
Question for you. What unintended consequences have developed or are developing?
Unintended consequences. So I'm thinking, we recently had a conversation about Ford sets hospital budgets. We had hospitals that had more revenue than they expected. It prompted a very vigorous debate about should those dollars go back to premium payers, or should they be invested in community resources that help people be healthy? One of the things that I think we missed in that debating back and forth, which became quite vigorous, was that we wouldn't have had that debate if there wasn't a transparent process for people to even know that there was something to debate about. And I don't know that people understood that as an intent, so I don't know if it's an unintended consequence, but I think it's something that we really come to understand on a deeper and deeper level. What does it mean when we put the system to be more transparent to the average person? People then have weird things to say about it, right? And that's unpredictable.
I'm inferring from your remarks that once the budget's approved, that a hospital or other provider does not have a right to anything, or excess of that, or?
They have to come back and present again to have that budget updated.
And also, real quick, if I may, is it just hospitals or is it other providers? Physician groups?
So the Green Mountain Care Board does have broad provider rate setting ability. They have not used that broadly, though, beyond their hospital budget process.
It's no secret that we're talking about this because we're paying the third highest in healthcare costs in the entire country. And I'm so forgetful, I don't remember where Vermont is now. And then the follow-up to that is, did this change the trajectory on your spending in some way that you find notable and you say, clearly this drove this spending down?
Yeah, I think that we can look at tangible topics like insurance rate increases have been lower because of the Green Mountain Care Board's review. In terms of overall system costs, a little bit harder to quantify in terms of the board's responsibility. But what has happened is that it has really driven, I think, our broader payment and delivery system reform, and some may have heard about Vermont's all-payer model that we're working on right now. I think that has been driven faster because of the role of the board. And again, the notion that there's much more focus on total system costs. We're not competing with you at number 3 in terms of per capita spending, but in terms of our ability to afford the growth, I'm not sure we have to be on that list to be able to say we can't keep up with that.
Thank you.
Good afternoon. Thank you for your presentation. My name is Irene Waldron, and I am the Executive Director of the Delaware affiliate of the American Healthcare Association, representing the long-term care continuum across the state. I've heard of you from my counterpart in Vermont. It's nice to meet you. My question has to do with the CON process, and I'm very curious to know how that shifted since the inception of the Green Mountain Board.
So it hasn't shifted so much in practice yet, but it has in dialogue. Because as we have moved with the board's direction towards more of a system-wide approach to payment and delivery system reform, that focus on paying for quality and outcomes has led people to say, well, then do we really need to then approve expenditures through something like CON? Or does it alleviate the need for that process? And I think we're kind of in this in-between state where we haven't fully implemented the payment reform models, and we still have some of those expenditures that you have to deal with, so we're kind of in between.
I have one quick follow-up. In Vermont, is your CON process, which is a certificate of public review in Delaware, does it use a methodology around bed need that's calculated by a special formula, or how do you do that in Vermont at this time? Thank you.
I don't know if it's grounded in specifically an assessment of bed need. I think it's more a review of whether the investment serves the public good.
Yes, hi, I'm Mark Thompson. If Wayne's known as the hospital guy, I'm known as the physician guy.
Awesome.
Welcome here to Delaware. Quick question. So what impact, if any, has this had on the state's ability to recruit and retain physicians?
You can make that case in any direction you want, I believe, and people have. I think some have raised concern that this is going to drive providers away. Other people have argued that this is creating a system, and by this, I'm going to say not just the board, but the whole effort driven by the board to reform how we pay for and deliver services to Vermonters. That it actually, if we achieve the goal of simplification, administrative simplification, and focus on the provider experience, that it is creating the kind of place where people want to practice. And so we still see some providers leave, we still see some providers come, and people will make their own arguments about what's related to each one of those.
So regarding the development of the board, if you could just maybe describe a little bit about the nominating process and vetting and Who actually controls that? You're careful to keep the independence of the board.
Yeah.
How do you keep the politics out of the nominating process?
Sure. So anybody is able to apply when there's an open position. There is a nominating review committee made up by the appointment of the governor and the speaker and the president pro tem. That board then reviews each application, including interviews. Again, the key piece is that their review is this candidate qualified to serve on the board? So they're not making a recommendation that this person should be appointed, that person should be appointed. They are providing to the governor, we believe that these people are qualified to be on the board. And then again, the governor makes an appointment that has to be confirmed by the Senate.
I'm going to take the prerogative of moderator final question before we let Mark go. I wanted to ask about community engagement. You talked about the public engagement process, but one of the hallmarks of the work we've done here is the broader stakeholder group in the business community, higher education, hospitals, private practices, insurers, everyone around the table. How does the board engage with that level of discussion beyond just a regulatory oversight relationship? How do they engage? What mechanisms are in place for that?
So I believe in statute, we actually require the board to have 2 advisory committees, one of consumers and one of providers, with the notion that they have to have some structured input. And then again, going back to what started through our SIM grant, was a very complex web of work groups related to any number of topics that provided a public-private opportunity for people to engage in, again, a series of topics related to the board's activities. And then we also ensured that board meetings are subject to our open meeting laws. So people just know when they occur and can have the ability to participate.
Thank you, Mark, for that.